Well, I want to welcome you all to our discussion today, hosted by Seeds of Healing and for our SOH Time platform. Today's discussion is So You Know About HIV Medication Holidays. Today, before we start our program, I would like to let everyone know that this event is being recorded. So if you do not want to be a part of a recorded webinar, please remove yourself. Only those who are on the panel are seen on video. However, our attendees can definitely drop questions and answers and comments into the comment box, and we will share them anonymously. Today, we have before us three wonderful panelists who will be having this discussion about medication holidays. And they are Tamisha Isaac, Mandi, Boykin, and Jenelle Montgomery. Before we get started on our discussion and offer our bio of our panelists, we would like to share with you SOH Time. SOH Time is our platform designed for women who are living with a diagnosis of HIV and is a place for them to gather to, I would say, network and basically support each other in their self-care behaviors. But I will allow the SOH Time platform to speak for itself.
Hey ladies, welcome to SOH Time. My name is Benita Spradley, one of the moderators and content contributors here, and we're excited to have you aboard.
Hello, Queens, and welcome to SOH Time. I'm Tamisha Isaac, also one of your moderators and content contributors. I'm honored to have you join us.
SOH Time is a platform for Black women to connect across the U.S. to provide tools for self-care and encourage consistent adherence.
SOH Time is a platform for us, created by us, to collaborate and center issues that affects Black women, the struggle causes by a diagnosis or chronic illness.
We have groups with specific topics to cater to the mission of SOH Time, but uplift, empower, and strengthen you as we power through on this journey.
Surrounding yourself with women that look like you in a safe space where you are free to be yourself while learning from each other and sharing resources that can enhance your way of life on the course of this journey.
We are here for each one of you. We welcome you, and we look forward to networking, supporting one another, and learning new things as we come together on this SOH Time website.
Welcome.
Thank you. So now, without delay, I would like to introduce to you first Ms. Tamisha Isaac. Tamisha Isaac is an HIV advocate and single mom of two boys. She recently did an interview with our Seeds of Healing So You Know Tri-Annual newsletter with her son, Rashad Barrow, her eldest son. They shared their journey of changing lives by sharing their lived experience as an openly HIV positive woman, and Rashad being born HIV negative due to Tamisha's adherence to her antiretroviral medication. Before the end of this show, I will definitely share that link with you all, and you can watch the video at your leisure. Learn more about Tamisha, an award-winning founder and CEO of Ms. Misha's World Empowerment LLC, which is at openlypositive.com. We too will share that with you before the end of this segment. Now, Ms. Mandi Boykin McCoy, she is one of our presenters today, and Mrs. McCoy is a PharmD. She is a clinical pharmacist with UNC Health. She serves as the lead clinical pharmacist for the Carolina Assessment of Medications Program, better known as CAMP, the CAMP Clinic, as well as a clinical pharmacist practitioner at Carolina Advanced Health. Dr. Boykin has clinical experience in chronic disease state management, polypharmacy, and medication access. Her professional training includes HIV management. Her approach to care is to develop relationships with patients and their healthcare providers to provide patient-centered care and optimize medication regimens by ensuring safety, efficacy, and affordability. Our next panelist is Dr. Jenelle Montgomery, who is also a PharmD. Dr. Montgomery is a clinical pharmacist practitioner with Duke Neurology Clinic and adjunct faculty for the UNC Eshelman School of Pharmacy. Dr. Montgomery has clinical practice experience in rheumatology and has transitioned her focus to a neurological disorder management. HIV management was incorporated into her clinical studies, and she has ongoing experience with specialty pharmacy and immunosuppression management. So without further delay, Dr. McCoy.
Today, Jenelle and I will be talking about HIV medication holidays. And as LaShonda mentioned, I'm Mandi Boykin McCoy, and you guys will meet Jenelle later on in this presentation. So before we get started today, we don't have any relationships with commercial interests related to the content of today's presentation. Our objectives for today are to review goals of antiretroviral therapy. We'll discuss medication adherence and its importance in relation to HIV treatment. And then we will investigate data related to HIV medication holidays. So before we take a look at today's topic of discussion, which is medication holidays, I just wanted to take a look back into antiretroviral therapy and why these medications are important and why they're taken in the first place. So the primary goal of antiretroviral therapy is to maintain maximal viral suppression of viral load. And as a result of that, it leads to reduced morbidity or mortality, which then increases survival rates. We are preventing transmission of HIV and then also improving duration and quality of life. So when we think of medication adherence, essentially it is defined as taking medications as prescribed. And specifically with medication adherence in HIV management, it's really important in order to prevent any disease or resistance, to slow the progression of the disease, to reduce any destruction of healthy CD4 cells, and then ultimately, again, to suppress viral replication, which then leads to an undetectable viral load. So effective use of antiretrovirals requires not only patients to be really adherent, but also to sustain that adherence over time. When thinking about the medications that may be given for management of HIV, there are some reasons why patients may have poor adherence. And I've listed a few of those reasons here. So complexity of regimen, multi-daily dosing, taking multiple tablets per day, potential medication side effects. Another reason would also be poor health literacy as far as why these medications are important, or limited knowledge of disease. There may be limited medication access. So from a provider standpoint, sometimes the cost of the medication isn't necessarily looked at or considered, or there may be formulary restrictions on a patient's insurance plan that would prevent them from getting the medication that a provider may potentially think is the best therapy for them. From a patient perspective, there can sometimes be disbelief in drug effectiveness, which again may be related to poor health literacy or limited knowledge of disease. There may be some hesitancy to discuss or to disclose HIV status, and so hiding that status may result in decreased adherence to the medications and not taking them as prescribed. And lastly, mental health or substance abuse issues may also play a role. So there may be depression or some sort of psychological disorder that may prevent individuals from staying on top of their medications as prescribed. And then with substance abuse, depending on how the level of that also could interfere with the frequency and duration that medications are taken. So as far as adherence statistics, this first calculation here is more so just to let us know that When looking at different studies that may take into consideration adherence, adherence is defined as greater than 80%, and that's what's considered to be good adherence. The rate of adherence, though, and the importance of that rate of adherence may vary and be affected by the outcomes depending on medication classes. So, for example, with patients who may be on protease inhibitors, adherence rates less than 95% may result in failure or reduced viral load suppression. And then another example would be patients on NNRTI-based therapy. Their adherence rate requirement may be a little bit lower at 75%, but anything less than that 75% may result in resistance to mutant strains. Looking at adherence rates of greater than 95%, they could be higher for patients depending on the regimen complexity. So again, this is another potential barrier to adherence is complex regimens. But what the data suggests is that patients who take one pill per day, 47% of those patients are able to achieve an adherence rate of 95% or higher. This is also the one pill per day regimen may be associated with lower hospital risk as well. For patients who are on the 2 pills per day or more, you can see that their adherence rates or achieving that 95% is a little bit lower at 41%. And as you go down to 3 pills per day, about 34% of those patients are able to achieve that 95 percentile mark. So what are some ways to improve adherence? Addressing barriers upon therapy initiation. This is something that patients and providers can work on together. So making sure that you are comfortable or that the patient is comfortable with why they're taking the medication, what potential adverse effects there are, what the potential cost could be, is it on their formulary? These are things that we can address upfront prior to prescribing the medication for the patient, or questions as a patient or caregiver that you can ask the doctor before getting started on therapy or delaying any sort of therapy starts. The use of adherence aids. So these are things such as setting a reminder, an alarm reminder on your phone, making a medication list and keeping that on your refrigerator, having a support system, or someone at home that's holding you accountable, using a pill box, different things like that that can help you and make the medications more accessible so that you can remember to take them. Simplifying regimens and decreasing pill burdens. Again, this is kind of a patient and provider collaboration because single tablet regimens, taking pills once per day may be easier for people to use. And there is better data, as I suggested earlier, with the once daily regimens. So this could be combining tablets, so you're reducing the pill burden for the patient. And then lastly, taking into consideration patient lifestyle. So one of the things that you can take a look at as well is choosing agents without food requirements, because sometimes the patients may skip their dose of medication thinking that they need to, or because it needs to be taken with food in order to help the medication work better. But if a patient isn't eating consistently, or if there's some sort of food insecurity or affordability concerns, this may not be the best option for them. So again, all of these things to improve adherence are things that patients and caregivers, as well as their providers, can work on together to ultimately improve the adherence rates. Overall, the importance of adherence, based on the information that we've gone over thus far, better treatment adherence in HIV is associated with better viral suppression. Poorer treatment adherence in HIV is associated with less effective viral suppression, which is our ultimate goal. It can also lead to drug resistance and reduced survival. And then medication non-adherence in HIV, and I thought this was a pretty staggering statistic, accounts for about 125,000 preventable deaths each year, which is about $300 billion in avoidable healthcare costs. So overall, the pharmacist in me just wants to reiterate that better adherence leads to improved outcomes. So going back to today's topic, medication holidays or drug holidays, what does that mean? It's essentially taking a break from your HIV treatment It can also be referred to as a drug vacation or a treatment break. Ultimately, it's an interruption in antiretroviral therapy, and it's thought to be a method historically, it was a method used to regain drug sensitivity or reduce medication side effects or toxicities. There are several different types of therapy interruptions. We'll talk about the three major categories of that. There's structured interruptions, unplanned interruptions, and then short cycle interruptions. So structured interruptions are scheduled periods of time when treatment isn't prescribed or administered. This strategy was once considered as a method to help patients to reduce any sort of medication-related side effects, or if patients had cost concerns, would be a way to stop therapy temporarily on a scheduled basis to kind of combat those barriers. However, what the data suggests, and Jenelle will probably allude to this later on, is structured interruptions are associated with higher rates of death, morbidity, and mortality compared to continuous therapy. Continuous therapy here being taking medications as prescribed on a scheduled basis without any breaks. The second type of therapy interruption is unplanned, which is a temporary discontinuation of the treatment. I've listed here a few examples of why you may have an unplanned therapy interruption. So this could be an acute illness or surgeries that prevent oral intake or being able to take your medications prior to. If there's a medication toxicity, it may be stopped by a provider, or if there's some sort of lack of medication access, whether this is the pharmacy has to order your medication and they don't have it available at the time, there's a cost concern, you're waiting on a prior authorization, different things like that. And then lastly, short cycle therapy interruptions. This is an alternative option to restarting treatment after side effects occur or after CD4 counts decline. Typically with short cycle interruptions, it's either a 3-day on regimen and 3 days off, or a 5-day on regimen and 2 days off. So looking into some of the studies with short cycle therapy or SCT, there were a couple that I looked at that were, the first was the 4 days on, 3 days off. So there were 32 participants in this study. They were children and younger adults ages 12 to 24 years old. They had to have at least 6 months of documented viral load suppression. Their CD4 counts were greater than 350. And then they had received protease inhibitor-based antiretroviral therapy. So with this short cycle therapy of the 4 days on and 3 days off, viral load rebound, so their viral load increased in about 12 of those patients, but there wasn't really any impact on the CD4 count. Taking a look at a second study, again in children and young adults, I believe these were ages 8 to 24. It looked at the safety and any potential benefits from short cycle therapy. And so patients were randomized to either receive short cycle therapy or continuous therapy. They were receiving EFV plus 2 NRTIs, and then viral loads were suppressed for at least 12 months before they participated. With this study, there were several patients who experienced viral load failure, and then 5 patients who were unable to regain suppression of their viral load that they had previously seen within the 12 months prior. So in general, short cycle therapy, the thought is that it could be potentially beneficial in some patients. Both of these studies looked at children and younger adults. I don't think that the benefit here, though, of the potential for toxicity outweighs the risk associated with not taking the medication, potentially not being able to get the viral load suppressed, which is the ultimate goal. But overall, these were short-term studies, and so there's still longer-term studies and more data that's needed, which if you were on the call last time, that was a lot of the information that was received then. More data is needed to make that decision. But I think when you take into consideration the information that Jenelle presents, you'll be able to get a better understanding of what we should potentially do as far as HIV and drug holidays for this specific patient population.
All right, thanks, Mandi. So I'm going to talk to you about, first about why do people want to take medication holidays? So Mandi talked about some of the reasons that I have on here. So it's starting with side effects. So HIV medications can carry a lot of side effects and toxicities with them. So that can range from nausea, diarrhea. Some people can have, oh, the chat box here, let me see if there, oh, great. Thanks, Mandi. Some people can have some neuropathy, so that pain or tingling and numbness. Some people can end up having more severe toxicities, such as liver toxicity and kidney toxicity. So some people might just want to take a break from having any sort of side effects and toxicities. Another thing is medication and healthcare fatigue. So that might range from having a medication that you have to take every day. Remember to take that same medication every single day and not miss doses if you can. And also your interaction with the healthcare system. So there's a lot of interactions with doctors' offices, pharmacies. You might not just have HIV going on, you might have other disease states where you have to see other specialists and primary care providers. So that constant interaction can kind of start to wear on you over time. Another thing is people might think that it might improve your quality of life. So again, not having to take medications every day and having to interact with the healthcare system might improve your quality of life. And if you don't have side effects, perhaps you'll feel better from that perspective. In regards to decreased cost, so we have a lot of patient assistance programs and copay cards these days, but maybe you did lose your insurance, or maybe that $30 copay is significant for you. So cost is certainly a consideration as well. There are also many drug interactions with HIV medication. So for example, common ones are like seizure medications that you may or may not be able to take, or maybe a statin for cholesterol. There's a lot of interactions there. So you certainly want to, remain cognizant of what you're getting, whether you're in the hospital or taking a medication at home. That's something to kind of continue to consider as you continue on your regimen. And then, of course, life happens. So, you might have some negative experiences that impacts your ability to remain adherent. So that might be you're hospitalized, or let's say you got into a car accident or something kind of big that happens that decreases your motivation to take your medication on a daily basis. And then there could be good life experiences that might decrease your adherence. So, for example, let's say you get to travel for 6 months and you don't know how you're going to get your medication and keep it and obtain it where you're going. So maybe you have a new baby or a new house, and just different things that might interfere with your day-to-day medication. Also, clinical trial participation. So let's say you're taking a medication and you can't take that medication in order to enroll in a certain clinical trial. Or let's say that there's a trial where you have to stop your medication for a certain period of time beforehand. So those are definitely some considerations that might lead someone to not want to take their medications. Also, improving long-term adherence. So you might think it might be the other way around, but maybe you just need a break. So maybe it's the idea that you go on vacation and then when you come back, you're remotivated. So taking a break for a while, and then you might want to come back, and then you're going to be kind of on it and taking it every day. And then there's another thought, it's called an immune system boost. But what the idea is was that if you stop your medication for a certain period of time, maybe you'll be able to develop a wild type or a strain where you're not resistant to certain HIV medications. Now that's been a little bit disproven, and we'll talk about what the risk of that is. But here are some reasons, common reasons why people might want to stop taking their medications for a certain period of time. Then what are the risks of taking a medication holiday? So even though this list is shorter than the last slide, it doesn't mean that it doesn't have a bigger impact. So Mandi mentioned the medication resistance. That's a big concern with HIV medications. We don't want when you become resistant to medications. And then also, we just talked about improving quality of life, but potentially it could lower your quality of life. So related to the third point, perhaps you would have more HIV-related illness or disease progression. You might start feeling bad, so that could potentially decrease your quality of life. And of course, you could potentially increase your transmission risk if your viral load starts to increase. And then also it may impact your motivation and adherence. So we talked about on the last slide about improving your motivation, but maybe you stop it for a period of time and then you don't want to go back on it. And then eventually it could potentially lead to that HIV related illness. So we're going to talk about two studies where they looked at this question. So this is where we get our information from about what happens if you're going on these drug holidays. So there's two big studies that happened. The first is the SMART study, and this was called the Strategies for the Management of Antiretroviral Therapy. It included a very large amount of patients, so 5,400 participants who were diagnosed with HIV across 33 countries. And the people who participated had a CD4 count of greater than 350 at baseline. So here are the two different groups. So the first group was the viral suppression group, or the VS group, and their antiretroviral regimen was continued with no interruption. So I have a little key in the bottom corner of your screen. So on the future slides, you can see which group I'm talking about. So the viral suppression group, their regimen was continued uninterrupted. Then you have the drug conservation group. So what they did with this group was they discontinued treatment until the CD4 count dropped below 250. Then they restarted it until the CD4 count went back up to 350. And once it got to 350, they discontinued it again. So it's kind of like a bounce between 250 and 350 in terms of how long they would discontinue the medication. The investigators of the study wanted to see what the impact would be on each group on infections, so opportunistic infections, either new or recurrent, or death from any cause. The type of people that enrolled in this trial, so 27% of the participants were women, 29% were Black. The median CD4 count was 597 at the beginning of the trial. In terms of the HIV RNA viral load, so 71% of patients had a viral load of less than 400 copies. And the most common regimen was zidovudine, lamivudine, and efavirenz, and that was about 10% of the participants. Now, with the SMART study, this study was stopped early. So it was stopped because there were some safety concerns in the drug conservation group. So that was a group that had the treatment interruption. And the average time in the trial was about 16 months. So for people who aren't familiar with reading trials, so when a trial is stopped early, something big has happened. So it could be a good thing where the benefit of one medication significantly outweighs the other medication, or there could be a medication or a situation that's more harmful. It's so harmful that it causes the study to be stopped. So let's see what happened with this study. So for the CD4 count in the HIV RNA viral load, so that worsened rapidly in the group that had the treatment interruption, so the DC group, or drug conservation group. And that happened within the first 2 months after stopping treatment. So the CD4 count decreased by about 87 points per month. So over that 2-month period, it went down by about 160. And then the percent of people with the HIV RNA load of 400 copies or less, that decreased from 71.8% to 6%, showing that it's becoming more and more uncontrolled. And then throughout the trial, the group that had the treatment interruption, DC group, had a lower CD4 count compared to the viral suppression group, the continuation, by about 206. They never really got back to the point where they were having similar CD4 counts. And then just in general, the group that had the treatment interruption, they received treatment for about 33% of the time. And then that was compared to 93% of the time in the group that did not stop treatment. And then in terms of what they were looking at, so the infections and death. So 120 participants in the conservation group, so the treatment interruption group, versus 47 in the group that continued their treatment experienced an opportunistic infection or death occurred. So when you look at the kind of ratios of what happened, so the risk was about 2 times greater in the treatment interruption group compared to those who continued treatment. The type of infections that happened were pneumonia and a fungal infection in the esophagus were the most common. The reasons for death were cancers, cardiovascular disease, other infections, which was interesting, and then substance abuse, and there was an undetermined cause as well. So if somebody likes to look at this in like a graph form. So when we're looking at this type of graph, the top line, so the drug conservation group, you can see that the line's steeper and it separates from the viral suppression group. So you can just see there, just by looking at this graph, that there was a greater probability of having an opportunistic infection or death, just looking at the separation in those lines. And then 65% 65 participants in a drug interruption group had at least one episode of major cardiovascular, kidney, or liver disease, compared to 39 in the viral suppression group. So it was interesting because they actually didn't expect this finding. And what they were thinking in this trial was that by being immunodeficient, it relates to these types of events. And the relationship is that an immunodeficiency can cause or relate to inflammation that can cause the cardiovascular, kidney, or liver disease. So this was just an interesting finding that they didn't anticipate when they began the trial. And then again, the same thing in the graphical form, you kind of see that separation in the lines, and the drug conservation group had a higher risk of these events compared to the group that did not stop treatment. And now we move on to the DART study. So this is a development of antiretroviral therapy in Africa study. So this is a little bit different. So it looks at the structured treatment cycles that Mandi was talking about. So their structured treatment style was 12 weeks on versus 12 weeks off. So you take medication for 12 weeks and stop medication for 12 weeks. It was included 813 participants diagnosed with HIV and took place in Uganda and Zimbabwe. And the CD4 count was greater than 300 at 48 to 72 weeks after their initial HIV treatment start. So again, we're going to break up the groups. So the first group is the continuous treatment group. They continued uninterrupted. And then we have the structured treatment interruption group, the STI group. And they did those cycles of 12 weeks on and 12 weeks off. And so the outcomes were a little bit different, but somewhat similar. So they looked at the World Health Organization stage 4 events. So it's a very long list, but some examples are low blood counts, if your liver enzymes were elevated, you had kidney failure, rash, diarrhea, cardiovascular events. So those are examples of the type of events. They also looked at death, and they looked at serious adverse events. In this trial, the type of people that were enrolled, so it was 74% women, the CD4 count was 358 on average at the start, and then 71% of patients had a HIV RNA viral load of less than 400, and the treatment was tenofovir, abacavir, and nevirapine. So again, this is the second study where the trial was stopped early due to the safety concerns in the structured treatment interruption group. The average time in this trial was about 51 weeks. And again, a similar outcome as the last study. So they had CD4 counts that decreased rapidly in the treatment interruption group within the first 2 months after starting treatment. So also similar to the other trial, it was about 165 to 194 of a drop in the CD4 count. And then 50% of the treatment interruption group had a CD4 count of less than 200 during treatment, and 10% had experienced less than 100 during the treatment interruption. And then on average, the STI group received treatment for about 50% of the follow-up time compared to 99% in the continuous treatment group. And then this is a really good graph looking at CD4 counts. So if you look at the top part of that graph, the kind of flatter line, so that's the continuous treatment group. And what you can see is that with the CD4 count, it kind of remains sort of stable at around 400. You can see below there that kind of bounce when someone's stopping and starting treatment during those 12-week cycles. And that CD4 count never gets back to where it was if you were continuing your treatment. So in terms of the stage 4 events I was talking about, so that happened about 2 times more often in the treatment interruption group. And similar to the other trial, there were fungal infections of the esophagus, extrapulmonary tuberculosis. And in terms of death, there were 9 participants that died due to HIV-related causes, substance abuse, cancer, and also an unknown death. And these events occurred more often for infections, the stage 4 events and in death occurred more often after the first treatment interruption compared to the other treatment interruptions. And then also another interesting finding is that in the interruption group, they required more hospitalizations compared to the continuous treatment group. So 11% of those participants versus 7%. And then also in the interruption group, there was more participants who reported being too sick to work and had more visits to a healthcare center compared to the continuous treatment group. So overall, what these studies show is that even if you want to take a medication holiday, it is very risky to do so. There's a rapid rebound in the viral load, the CD4 count becomes uncontrolled. So it is certainly a risk to take in order if you stop your medication. So it is common to want to take a medication holiday. There's very good reasons to want to. However, it's not recommended to take a medication holiday due to the risks. So that's a risk of disease progression and then other adverse effects. So overall, the risk will outweigh the benefit over the short and long-term periods. So if adherence is a concern, you should talk to your pharmacist or your doctor about ways to minimize side effects or medication fatigue, and also considering addressing fatigue in different ways. So perhaps it's taking a trip, or perhaps it's kind of changing your lifestyle, or different strategies to remember to take your medications. So there's definitely ways to address this, and hopefully this information we shared with you today is helpful in making that decision. I want to thank you for joining us.
That was awesome. Awesome information. Thank you. Thank you. Thank you so much, Jenelle and Mandi. I learned a lot just from there, and give me some perspectives as a provider. But now what I want to do is to turn it over to Tamisha Isaacs. Again, Tamisha is, she's an HIV advocate, and she has a diagnosis of HIV, and her perspective and questions and comments are going to be really valuable. Tamisha?
Thank you. Thank you. That was really great information, even though I know you guys answered a lot of them already in your presentation. One of the questions is, if I'm undetectable, can I still stop my medication?
Go
ahead, Jenelle. You're good.
So yeah, so that's a good question. So based on just the information from those trials, it does not take much or a very long period of time for those numbers to change if you're not on treatment. So even if you're undetectable, there is a risk of becoming detectable. So I would definitely say that is a potential risk, and those numbers can change very quickly.
Awesome. That's great. There was more questions that was asked. I can't find my email, Lily. Even though I'm the one that asked the questions, and I remembered and I forgot them.
Oh, the questions that you sent in? Well, I have a question. Can I ask you a question, Tamisha, while we locate those questions?
Of course.
Yeah. As a person living with a diagnosis of HIV, what actually do you find in your conversations with your peers to be the most reason that someone may decide? I know they listed a lot of reasons, but what do you all know?
For many of them, it's medication fatigue.
Mm-hmm.
That's one factor. The next major factor is the shame, the guilt, and them not, wanting anyone to find out about their status. So they choose to not take their medication or hide them, and then they just live their life, and then they become ill.
Okay, thank you. I want to remind our attendees that they can also send questions and comments through the chat.
So Destiny sent in the question. So what are the risks when thinking about taking a medication holiday, which Mandi and Jenelle so eloquently explained and broke down, the risk factor. A lot of the risk is you become detectable again. And sometimes resistance to medication, and also it's hard to get back to that undetectable or suppressed level, because now your body is going through a whole transition and possibly probably mutating, and it's not adhering to the medication. It's not working. The medication is not working. I can't medically say what you guys say, but that's one of the things that happens as well. The next question is, Mandi and Jenelle both answered that. Will there be a risk in viral load spike? Yeah, there will be a risk in viral load spike. Let me see. Can medication holidays cause other complication other than HIV? Jenelle or Mandi?
Yeah, I mean, that was just an interesting finding in that trial about having more cardiovascular disease and liver and kidney disease that they didn't expect. And usually when they design trials, they kind of expect certain things to happen versus not happen in general when we're first starting. So that was definitely an unexpected finding. And just another point to, it's not just becoming detectable. There's other disease complications that can happen, and you can end up in a doctor's office for a whole other reason than having HIV.
Absolutely. I feel like for most of us, people living with HIV, especially the ones of us who's not open or who's not comfortable sharing our status, I find that it's more difficult for them to adhere and to stay into care because of that burden that they're carrying and risk of, someone finding out. It takes them a longer time to adhere to their medication, opposed to the people living with HIV who is a little bit more open about their status, or who is more comfortable talking about their status. That's another issue that I find within our community as well.
Yeah. I would just like to add, from the perspective of a provider, I think that has been a contribution to why I may be a little bit more attentive about simplifying regimens, so that, the less pill burden or the less bottles that clients have to juggle might be helpful along their journey, as they cope with the diagnosis. So, yeah.
This was great. This was a great topic. Thank you, ladies, for covering so much.
How much more do you suspect injection medications to help in decreasing drug holidays?
Yeah, I think I think injectable medications can certainly help with adherence and not having to remember to take something every single day or multiple times a day. However, I think this is very similar to my answer from last month, is not everyone's a candidate for injectable medications, whether that be injection burden or fear of injectables, or, are you going to be able to remember? Is it easier to remember to do something every single day because you're in a routine to do it, or do you do it weekly or a couple of times per week? So I think it's very individual specific, but I think either way, taking less off of the patient, whatever is most convenient for them, and catering to their lifestyle, like I mentioned, as far as adherence goes, you always have to take that into consideration as well. So Benita, maybe, you go to church on Sundays and it's easy for you to remember after church, I take my medicine. Whereas somebody else may say, I need to do this every single day. But I do think overall at this point, like realizing the importance of adherence and being more familiar with disease and your health status, I think will ultimately help cut down the fatigue, as Jenelle mentioned, and increase your awareness for the importance of taking the medication and remaining undetectable if that's where you're at.
We had another comment from an attendee, and they shared, I was undetectable and substance use played a huge role in my non-adherence. And I missed 1 dose a week, and in 3 months, my viral load was detectable. Thank you for sharing that. So just 1 dose missed out of 7 days, and after 3 months, that viral load became detectable. So no matter how few, it still can have impact on your outcome for viral load. Thank you for sharing. And that goes back to the
Absolutely.
point, Mandy, about individualized care, knowing what your clients are dealing with. Tamisha, sorry.
No, it's okay. I was actually going to add to that comment. In my early years of being diagnosed, when I was diagnosed when I was 19, I was a teenager, and the first couple years was rough for me because not only I wasn't on art therapy, I was on cocktails. This was in 2003. Kaletra and Combivir was one of the two medications I was on. Kaletra gave me headaches and made me very, very sick to the point where I would cold turkey stop my medication, and then I became resistant to those strain of medication. My doctor had to do a whole resistance strain blood test on me to see which medication he can give me, which medications he can't give me. And that in itself alone is not only stressful for me as the patient, but it was also stressful for my provider, because now he's like, I got this teenager, what am I going to do with her and her not taking her medication? And I did this religiously. So medication vacation that's what I did. I did that because it made me sick, because I hated taking my medication. And then Virate came about and I got on Virate, and then I had my son. And then that's when my perspective on taking my medication changed. After I was pregnant with my son, and I did not want to transmit HIV to none of my kids. So my perspective on that definitely changed. And that's when I made a vow to myself that I would take my medication at night before bed when I'm about to go to sleep, because it's better for me that way. Not only do I remember, but then it doesn't affect me in any way. And I've been doing that religiously for the past 15 years now. And I've been diagnosed for almost 20.
Thank you. Thank you for
That's
sharing.
a very important point, as far as, if you are having side effects from a medication, establishing a relationship with your provider and not being afraid to tell them what's going on, or, hesitant to have them switch you to a different medication. I think there are so many different options now that you can choose to help you out, that a lot of patients just don't understand that, and they think that they look at it as a failure, not only the medication's not working, but upon themselves, that they have to say, hey, this isn't working for me. But times have changed and there are more options available. And so if that is the case, then it's definitely important to speak with your provider or pharmacist and kind of get some insight about that.
I want to thank you all for a wonderful discussion. I think that the takeaway from here is that the risk definitely outweigh those short-term benefits of a reason to take a break. So as Dr. McCoy just said, continue to work with your provider about those things that impact your adherence. And hopefully you can have a regimen that can keep you more consistent in your medication management. Thank you for sharing, Tamisha. Thank you, Benita, for being here as well. Dr. Montgomery and Dr. McCoy, you guys, again, hit it on the head, and we so value and appreciate you for taking out your time for everyone. So we're going to end tonight's discussion. Look forward to some more webinars that we have coming before the end of this winter. We're going to take a twist on maybe some more psychosocial conversations. So look forward to our marketing that will come out, and you'll be getting that information in your email soon. So we're just going to share with you our SOH Time platform again, and we hope that everyone have a good evening or good day.
Hey, ladies, welcome to SOH Time. My name is Benita Spradley, one of the moderators and content contributors here, and we're excited to have you aboard.
Hello, Queens, and welcome to SOH Time. I'm Tamisha Isaac, also one of your moderators and content contributors. I'm honored to have you join us.
SOH Time is a platform for Black women to connect across the U.S. to provide tools for self-care and encourage consistent adherence.
SOH Time is a platform for us, created by us, to collaborate and center issues that affects Black women, the struggle causes by a diagnosis or chronic illness.
We have groups with specific topics to cater to the mission of SOH Time, but uplift, empower, and strengthen you as we power through on this journey.
Surrounding yourself with women that look like you in a safe space where you are free to be yourself while learning from each other and sharing resources that can enhance your way of life on the course of this journey.
We are here for each one of you. We welcome you, and we look forward to networking, supporting one another, and learning new things as we come together on this SOH Time website.
Welcome.
So there you have it. I hope that everyone have a great evening. We do have some literature to share with you as well so that you can read about medication adherence, some strategies that were shared from Dr. Montgomery and McCoy. So we're here and we'll be in touch. Have a good one.